So I'd like to welcome Dr. Jennie Wells, who's going to be speaking to us today about an update on the diagnosis and treatment of Alzheimer's dementia in persons with Down syndrome. Dr. Wells actually trained in the States and went to the Connecticut School of Medicine, and then she did her internal medicine also in Atlanta, and then came back and completed a geriatric subspecialty residency at Western. She's an internist and geriatrician, associate professor at the Department of Medicine, and she's actually assumed the role of chair of the Division of Geriatric Medicine as of June 2011. Her clinical research interests are in Alzheimer's disease and geriatric rehabilitation. She has a particular research interest in mild cognitive impairment and the potential for non-drug interventions, such as exercise and nutrition, and Mediterranean diet.
I'm trying to, that's enough.
Okay.
Got it. I had fire last night.
Okay, okay, that's enough.
I'm not going to mess with it.
So thank you for inviting me, all of you, for doing this talk. And it was 16 years ago, 2007. So some of my slides are from 2007. I spoke for the disabilities, the dual diagnosis group. And then I had to do a new literature search to update myself since 2007 about Down syndrome and what's happened. So thank you for the privilege of learning. So it was exciting to find that there has been some research done. I would say persons with developmental disabilities, I guess Down syndrome about 3%, but they're neglected in research. It's a little bit challenging to get consent or so forth. So it's a neglected area of research, but there hasn't been as much as I had hoped, but I was happy to see that there's been some in terms of the treatment of Alzheimer's disease with people with Down syndrome. So I do have disclosures. Yeah, I don't have any personal money that gets in my pocket. I try to refuse that. My other disclosure is I think I have imposter syndrome. I'm not a psychiatrist. I'm not a geneticist. I'm just a simple internist who, I'm a clinician teacher. I'm going to just do my best. Yeah, let's go on. You can read this. They're all available later. Oh, why is my formatting off? It was perfect. I did this talk for the Alice Sadi organization that got a little, yes, I did last week. I had a different slant for this one. And my slides didn't, that was perfect, my slides. Forgive me. I get evaluated on this, right? My slides are perfect. Okay, here's your goals. We're going to look at, and we have pediatricians, we got dual diagnosis psychiatrists, we got a neurologist, we have some of the support staff, nursing, family doctors.
Podiatry.
Yeah, I'm sorry. I hope I haven't missed anybody. But I'd like to keep a discussion going, and my preference is to keep it more clinical based with signs and symptoms recognition. There's some sciencey things in here that I think it's important to know. Some of the research has been done on the causes of why people with Down syndrome develop and what are other risk factors. So I'll try to breeze over that. So to be able to list the clinical signs and symptoms associated with mild cognitive impairment and dementia, and have some non-pharmacological treatment strategies, because really that's the foundation for treatment of cognition for people without Down syndrome. So it applies to them as well. And then we'll touch on the pharmaceutical treatment. All right, let's move on. So I have an outline for a roadmap that I'm going to jump around a bit, if that's okay. I'm going to skip over that. You all know the general physical features and so forth. I want to emphasize the medical comorbidities because they're very much prone. They have more inflammation in their bodies than people without, it's only 21. Then go through the physiology of why do they have more amyloid and why do they develop Alzheimer's disease? And then we'll try to focus on the meat of the cognitive behavioral symptoms and psychological symptoms, the foundation of making a diagnosis and treatment. Okay, so we'll skip this because you already know it. What that one is that? You already know that. Okay, for pediatricians know this. I remember being in medical school, yeah, can the kids see, can they hear? But there's lots of other medical conditions with, and I put the little check marks, see these little check marks? Oh, there. I just highlight, of all the patients I've seen with Down syndrome, I really don't have all that many. And I came about treating people with Down syndrome. I'm a geriatrician. I don't know anything about this. That's why I feel like an imposter. It was the connection through Alzheimer's disease. They came to me, so I had to be self-taught. That's why I'm an imposter. I never had training. Okay, so hearing loss. They have all these medical comorbidities, and then the developmental delay, sleep apnea. I'm very repetitive about sleep apnea through the entire talk because it's an underdiagnosed condition in people without Down syndrome. It's like suffocating. My mother taught me not to put a plastic bag over my head when I was 3 years old because it'll kill you. Not treated, sleep apnea slowly kills people. It actually contributes to the physiological changes of amyloid and progresses amyloid, not just strokes, heart attacks, and sudden death. Okay, so all these comorbidities. Oh, there's more. Joint and chronic pain. Seizure disorders from their little kids, and then I see them when they're older, they get seizures, and sometimes it's their parents bringing them in, and they're 86 years old. I have 2 patients. It's true, absolutely true. Other medical, and then I'm going to focus in on this. All right. So the other part is the Down syndrome in the late 80s in New England Journal. It was published. Oh, this was archived in Internal Medicine in 1982. It was recognized as really complex in terms of a marker of malignancy, endocrine dysfunction, prone to more infections, and progeria, premature aging. So we'll go through some of those causes. And then the effects, I can't go through, I'm not a biochemist and geneticist to know all of the effects of triplication of the chromosome 21, but there's a lot. Yeah, I'll get myself trained on this. There's a lot on mitochondrial genes that affect the mitochondrium. So that's free radicals with the energy battery system of our cells. 10 genes on just CNS structure and function, folate metabolism. So you get the picture. So amyloid, that's the big Alzheimer's one, 150% more amyloid is produced. Now this was what was new that I appreciate the literature search I did to prepare for this. This DYRK1A kinase protein, so it doesn't just increase amyloid, having 3 copies of chromosome 21. Oh, you all celebrated March the 21st? Yesterday, sorry, I just had to.
Sock day.
Sorry?
Sock day. No one is supposed to wear socks for Down syndrome on March 21st.
Oh.
Because it's 321, so you have 3 copies of chromosome 21.
Okay, I didn't notice. But anyway, wanted to acknowledge it was yesterday. But you know, the other part of the progression of the disease is with the tau proteins. So this was fairly new in the literature since 2007. So it's both the tau hyperphosphorylation and the amyloid. Then the other is, I mentioned the free radicals. So superoxide dismutase is part of the enzyme cascade that quenches free radicals in our bodies. You know, catalase, glutathione is the other part. But in the chemical cascade to quench free radicals, if you have too much or more superoxide dismutase, it creates more of the hydroxy free radical that's higher energy to create more oxidative stress in the body. And that can lead to progeria. Okay, another gene, this S100 gene. Don't ask me any questions about it. All I know is the abstract I read and scanned the article. It also is involved in inflammation. So that's new research since I did this review in 2007. Then again, obstructive sleep apnea, it shifts the metabolism of the big amyloid protein that's 800 plus amino acids. This is the bad. A beta 42 is the one that polymerizes and forms the plaques. A beta 40 is what we all hope is in our brains. So if you snore, go get screened. Okay. So people with Down syndrome, dementia, I think you already know, so maybe I should skip over this slide, is diagnosed much earlier than average in the rest of the population. And there are genetic risks, so I think this is too easy for you guys to know. So in people without Down syndrome, studies have shown in looking at markers in people with autosomal dominant early onset Alzheimer's disease, they do lumbar punctures and get CSF markers for the disease. Alzheimer's disease starts pathologically 15 years before the person has mild cognitive impairment or any memory loss. So that in a person with Down syndrome, with the other physiological risk factors they have, beta amyloid deposition starts at about age 12. Profound. The difference between developing Alzheimer's disease without Down syndrome and Down syndrome, I don't know why. However, the deposition of amyloid is more in the frontal lobes. That will cause some different early symptoms of the disease. And we'll go through some of them as I keep talking. There's the, the pointer I had last week. The laser was on the right side, sorry. I'll just go with it. So the deposition keeps going, and there's a few other areas that are affected, but the early features with Down syndrome, unlike early stages of Alzheimer's disease in people without Down syndrome, is there's a little bit more executive function, a little bit more frontal symptoms of, I don't feel like going to bowling tonight. I'm just gonna stay in my room. Another feature, don't have it here, is the language changes. Maybe it's on another slide. It's called pragmatic language. When I used the term pragmatic language, when I first read it in 2007, I didn't know what it was and I had to look it up. All right, it's the niceties of language. And so when I've trained my ear to listen for paraphrasic errors that people make and train my ear for language, I've heard it in people with Down syndrome where I'm just meeting them, their group home case manager is in the room, maybe they have a brother or sister or even a parent there, and we'll be talking on a topic. They will change the topic out of the blue. They will, and they seemingly, I met them for the first time, and they believe that I already know their brother, sister, or group home person. So it's the niceties of language of when you meet someone new and you have a friend that you know, that you are aware of that and you do introductions, or you do transitions from one topic to another. I hope I do that well in my job, or the assign. So that's pragmatic language, and that happens earlier in people with Down syndrome who are developing Alzheimer's disease. The other issue that I'll talk about, I think, later, is people with Down syndrome, see, I say that they're the same as all the rest of us. They're very heterogeneous in their likes, their dislikes, and their functional aptitudes. And I think all of you know that some people will graduate. I had a patient who graduated from university. She had a job. She worked in a legal office. It was probably adapted in some way for her. And I've had other people who haven't gone through any education at all. So their IQ and their aptitude, plus you'll see my A, B, C, D, F mnemonic in a later slide. The environment and how they're nurtured through their life is a big factor as well. So it starts early. The things that increase the risk and cause dementia at an earlier age in people with Down syndrome. Are there other genetic things? So I will ask when a person with Down syndrome, I ask when anyone comes in, tell me your family history. Do your parents have Alzheimer's disease? Do your parents, brothers and sisters have Alzheimer's disease? Oh, does it go up another generation beyond that? So the ApoE4 allele is the gene that's associated with the familial late onset Alzheimer's disease. When a person with Down syndrome happens to inherit, so the ApoE4 allele is not autosomal dominant. It increases your risk. It has to do with lipid metabolism as well as then amyloid metabolism. But if a person with Down syndrome has the ApoE4 allele, they may have dementia starting in their late 30s even. The youngest person with Down syndrome I've seen with Alzheimer's disease is about 37, 31. So then there's the wrong, never mind. I tried to press the laser and I advanced this line. And so the other thing about, here's the example in a graph. I love graphs, I'm very visual. Here's the green is the ApoE4 allele. People with Down syndrome with ApoE4, much earlier diagnosis of memory loss onset than the other groups. The ApoE2, even though there's the 2-4 combination, 2 is protective for Alzheimer's disease. So that's what that shows. And similarly, people with Down syndrome who have the ApoE4 allele, probably not a surprise. Here's the blue. Whoops, here's the blue. E4, die earlier. So this information, I think, applies to people with Down syndrome. There's no literature about people with Down syndrome, but it's true from the Canadian Study on Health on Aging, epidemiological studies of what's associated with dementia and developing dementia. And it's a lower level of education, decreased hearing. By the way, I just got these new hearing aids about 5 days ago. I lost the other one. Surprised I didn't lose it earlier with the COVID mask donning off, but I'm sure it's in a snowstorm somewhere at Victoria Hospital. Haven't found it yet. And anyway, and who's aware of deafness is associated with dementia? Big, yeah. So I'm even pushing hearing correction, and I think all the pediatricians know that already. Fixed ears, get them to hear, develops the brain. Low level of exercise for many reasons. And of course, I already talked about the Mediterranean diet before my talk was started.
When you say low level of education, do you mean number of years of school?
Yes and no. I believe that's how it was measured in all of the research that's been done, especially for that study that I'm citing. But when I do an interview, I don't count the actual years. I ask, okay, have you, through your lifetime, have you been on committees for your children's school? Have you done, gone to the social things? Have you, whatever, developed hobbies? So I have people with Down syndrome who played like 2 instruments, right? And they can read music. So that's education also. So it's, I'm morphed. But yeah, but I do ask about formal education in people with Down syndrome. Yeah, it's both. All right. And of course, the things that are bad for our brains are all the vascular risk factors and drinking too much. And I finally had one person with Down syndrome who's referred to me who has a beer once a month. And nobody has ever smoked.
Wow.
I don't know. Maybe you have others that do, but at any rate, so that spares them. Okay, this is just a pause because I think I'm going to be shifting gears. Oh. Okay, so my real key is, and I was telling someone else that what I do isn't rocket science. You don't need to send people with Down syndrome who may have behavior or memory troubles to me. It's all common sense. What's different about them? You get the history, what's changed? And it's in their mood and the behavior. That was in my disclosures, I have a saying, especially with people without Down syndrome or with Down syndrome, I don't treat numbers, I treat human beings. It's about what is their best level of achievement and whatever it is. whether it's their IADLs, best level of achievement. And so people say, oh, I've never cooked. Okay, you can make a sandwich. Oh yeah, well, that's cooking. As opposed to another patient who's been a gourmet chef. It's a similar thing with people with Down syndrome. What's your best level of achievement in? When you go to the grocery store with your group home worker, do they come up with spontaneous suggestions about what they want, or they just follow you around and don't recognize, you know? So to me, it makes sense. So that's all cognitive things. How we participate in our IDLs is what's meaningful. Having an MMSE of 14, who really cares? Doing objective tests is helpful because it gives my little academic mind an objective measure as opposed to a self-report or report of a collateral historian. So, and it can help validate what the collateral historians tell us about people. The symptoms I look for is that, again, I already said it in other ways: loss of spontaneity, loss of initiation, loss of interest in the activities they previously enjoyed. And then there's a spectrum for the psychiatrist in the room. Oh, the one psychiatrist left.
There's two of us here, the dynamic duo.
He's a psychiatrist, I know. Yeah. The spectrum of anxiety and depressive symptoms. And I'm going to mention another psychiatric symptom of obsessive compulsive traits. I only see people with Down syndrome who are already affected with memory, but I believe there's sort of obsessive compulsive tendencies before they have dementia from my reading. It's my thing, it has to go here. That can get exaggerated. So, oh gosh, I was psychic. I didn't know that was the next slide. So so they can get agitated. There's some behaviors that happen if they don't have the things in the exact order that they want them. So that's another sign and a red flag. Something is changing within that individual. Now, whether they have Down syndrome or not, if they have these sets of symptoms, depressive symptoms and anxiety can happen in mild cognitive impairment. There's other neurotransmitters other than acetylcholine, which is and glutamate, that are changed with the development of Alzheimer's disease. Serotonin is changed, and that's a frontal lobe neurotransmitter. So we know already that pathology in people with Down syndrome have more frontal lobe changes. So there is more of this apathy, disengagement, and universally I will start a person who comes to me and I think, oh, and plus they will, on the age, pretty much it's gonna be 100% guarantee unless they have a mosaic pattern of their chromosome 21, and it doesn't copy the amyloid segment, they're going to get Alzheimer's disease. But I will start them on an SSRI first. And then often it'll be a year later, the caregiver calls and says, they've improved, it was good, but now, and then I'll start a cholinesterase inhibitor. So, these domains are basically the same. The Canadian consensus guideline for what we should check for family doctors, for anyone who takes care of people with Alzheimer's disease, or their patient comes in with a chief complaint of, gee, I'm not doing the things I used to do, my memory's off, or that set of blood work, calcium, TSH, B12. Don't believe what the laboratory says about what's normal for vitamin B12. There's subclinical changes if the level is less than 300 picomoles per liter. Homocysteine will be elevated, methylmalonic acid will be elevated. Treat before it gets to clinical symptoms. So keep it above 300, and hearing and vision, and then other health conditions. And you saw the myriad of health problems that people with Down syndrome can have. The subluxation of the joint as they age, the arthritis. If they have pain and they are not particularly verbal or communicative, because there's a big spectrum of people with Down syndrome are very good at receptive language. As a generalization, a little bit poorer at expressive language. So they may not complain of pain, but treat the other medical conditions. Now, the other feature on physical exam are frontal release signs. And a higher MCV is associated with, MCV is, if I'm not sure what the group is how large our red cells are in the CBC. So a high MCV, I believe it's associated with dementia. It also, as you saw, the comorbidities, people who live long enough with Down syndrome will get mild dysplastic syndrome and have the bimodal of other, like leukemias. So the MCV can be related to the bone marrow dysfunction, and it's associated with aging. So that's a little clue to say, oh, this person with Down syndrome is aging, their MCV is 101. I wonder what their cognition is. And I believe there's guidelines to say at age 30, a person with Down syndrome should have a check of their IADLs and ADLs and what their general behavior is, to then compare as they go forward in age. The physical sign, frontal release signs, and I already mentioned the burden of disease that's happening more in the frontal lobes. So I use palmamental, the pout reflex, and the grasp reflex, which isn't really taught well in my medical students that I see, or even my first or second year residents. As another little physical clue, is there's what's going on in the noggin. Okay. This is just a reference, and I have all the references of all the abstracts that for this revised talk and the old talk, and this was in my 2007 talk to you folks. And it lays out the guidelines of how to work up and treat, and it's really quite simple. What's their best level achievement? What's changed? What do you do? And I've already referred to the Canadian consensus guidelines. All right, we've talked about that already. And as Dr. Cassidy said earlier, we all need an individualized, multidisciplinary, patient-centered care plan. Because all of these people have different likes and dislikes, and you create it based on who they are as an individual and what their talents are. Oh yes, here's my ABCDF. So you're gonna assess their affect, their behavior, their cognition, environment, and how we interact in the environment. If whether they have Down syndrome or not Down syndrome, if they're not, like social isolation. I've been talking my head off for the last 3 years for my patients who knows, everyone knows what BPSD is, behavior and psychological symptoms of dementia. Oh, the poor people who are isolated because of COVID. I got all these calls from their whatever daughters. Mom is pacing, she's agitated, she's refusing to eat, she's hit me. Oh my gosh. The environment matters so much, not to be isolated, have your brain stimulated. And function, of course, because that's what matters, where the rubber hits the road, is what can they actually do and perform. So the essentials are to get the collateral history. There's tools. So over the years, I've done literature searches to find the best tool, because there's a ceiling effect. The test is too hard. And I have my residents and students doing MOCAs on somebody who can't speak English, or they have grade 1 level of education, and they already have a diagnosis of moderate stage dementia. Ceiling effect, it's the wrong tool. Similarly, with people with Down syndrome, I have maybe half of my patients currently, I can use the MMSE. There's probably one patient that I've ever had in my 25 years of seeing people with Down syndrome that I think that the nurse did the MOCA, and that, gosh, they scored 16. But it's a fairly useless tool. So we wanted the best tool. And then in the search, they're all patented, and there is fees. So in terms of St. Joseph's budget to pay for the best validated tool, sorry, don't have it. So these are the ones that I work with. There's the Down syndrome aging checklist, which gets at a variety of functional activities of basic self-care. It gets at certain behaviors of agitation, hallucinations, and so forth. It has a few drawing simple pictures for the parietal lobe. the Cornell scale for depressive symptoms and dementia. It's been validated for a person who's cognitively intact, to self-report. It's validated for caregivers and family members who know them about depressive symptoms. I really like the Cornell scale for depression and dementia because it also gets at some of the, there's anxiety, there's depressive symptoms, there's suicidality, which suicidality is missing from the geriatric depression scale. And it gets at agitation, pacing, and restlessness, and fidgeting. So it gives you a broader picture of all the behaviors. The DMR, I think in Europe you can say the R word. I didn't say the R word at my talk for the Alice Sadi last week, but so that's why I didn't write it out. It's Dementia Questionnaire and Mental Retardation. It was a validated tool in Holland in about 1990. And that was the only one that didn't cost us hundreds of dollars to download. So we use this because it doesn't need any literacy on the part of the patient. And it reports on behavior as well as cognition. So there's subscores there. So it's a handy objective measure to follow somebody with Down syndrome where the other tools don't work. Okay. I already mentioned that people with Down syndrome are very heterogeneous. I think their IQs can range basically 50 to 75 or 80-ish. So there's a great spectrum. And similarly, and I should go to the cases. So I have two cases at the end. And I wanted to note the difference between those two patients in terms of their environment and their life story and what they achieved. So it speaks to the heterogeneity of assessing these people and how flexible we have to be as clinicians. We talked about the ceiling effect. The test is too hard, but for some there's a floor. There's also sorry, my mistake. I have this sick cat, and there's a picture at the end of my cat. So I only had like 3.5 hours of sleep. So the ceiling effect, the test is too easy. The floor effect, the test is too hard. Oh my gosh, I'm gonna get a bad evaluation for that. But the tools we have are poor measures of social and emotional intelligence. And that's what the strengths of people with Down syndrome are. They have high levels of emotional intelligence. All right. I have a gentleman with Down syndrome living in a group home, and his OCD behavior is washing his hands. And he hogs the bathroom, and his hands are all red. I even went to paroxetine, my hated SSRI. It only reduced it a little. So if you guys can help me, but these sorts of behaviors are frequent, and the affective symptoms are frequent. The other challenge in assessing people with Down syndrome is, I don't feel like doing it today. So there's a variability on their performance on tests. It helps to have an engaging personality. I'm generally fairly successful if the nurse tells me, oh no, I couldn't do the MMSE. Oh, hello, John. Tell me about your cat. Oh, yeah, your cat, good. Are there any other animals you know about? And so then I can do animal verbal fluency. It's just making it seem like real life is really about what it's like. Okay. Oh, I already talked about this. Depressive symptoms, indifference, who cares? The pragmatic language in the change in social discourse, got that one. Frontal release signs. We already talked about seizures. I already said that. Good. Guess I know my content, I just don't know the order of the slides. Yeah, so I highlighted this already in the beginning with the notation about the ApoE4 allele. So in the assessment is where this is linked in again, is to ask their family history, because that really increases the risk, particularly if they're 37, 38, 41. The other behaviors I see, they might be normal for someone with Down syndrome. Oh, they've always had the imaginary friend. And you're gonna have to tell me if that's normal for younger people with Down syndrome. By the report I have, because a lot of my experience is anecdotal, other than what I've read in terms of the treatment evidence. Oh, again, I told you I was gonna be redundant. Always screen for obstructive sleep apnea. Because I'm gonna say, if you can diagnose obstructive sleep apnea when they're young, as teenagers, through relatives and trusted friends, they're gonna be more likely to adapt to it. Then I get them when they're 45, when they already have cognitive impairment, there's no way they're gonna accept it. And then I say, oh no, it's too much work, it's too much trouble. So treat early. Yeah, so in terms of the research that I found that was done since 2007, in terms of my work in Alzheimer's clinical trials for Parkwood, there's disease-modifying medications that are emerging. So we look for the markers for disease modification, would be things that measure amyloid. This was a study of a magnetoencephalography, which I'd never heard about until I found this abstract, that they did a pilot with 28 people with Down syndrome. Some of them had some mild cognitive impairment and the other ones didn't. And they could predict pretty accurately with good sensitivity and specificity who are the ones who were impaired with this magnetoencephalography. That's great, but it's not clinically useful because who has that in their office? And so my next title here was a little bit nihilistic here, and they've done little trials with PET scans that show more amyloid deposition in the frontal lobes. Right now, I think in the United States, for people who have MCI, some insurance companies, if people have supplemental insurance there, might pay for an amyloid PET scan to diagnose them. Oh yes, this is the mild cognitive impairment of the Alzheimer's type. However, it's not realistic for general use, and we're not advocating for it. There's going to be other biological markers. So it's not practical. What is practical is common sense. What has changed in their level of function? What has changed in their social and behavioral function? Then there's evidence, and there's a Cochrane review that I'll get to in a minute. And in 2007, they already had multiple small trials with people with Down syndrome showing efficacy with the cholinesterase inhibitors. So you treat them just like everyone else. My anecdotal experience is, for my patients that I've seen, there's a higher risk of side effects with medications in general and with the cholinesterase inhibitors. So I usually start at half the dose and then titrate up. So the medications that are disease modifying, so aducanumab, if you've listened to the news, that's the one that the FDA approved, sort of with particular guidelines for MRI scans. So it's a monoclonal antibody against amyloid, removes amyloid from the brain. These aren't, and I've done the phase 3 clinical trials with aducanumab at Parkwood. Oh, exclusion criteria, people with Down syndrome. And these are the people, really, people with Down syndrome are the ones that probably might benefit the most from removing amyloid from their brain early on at age 12 and so forth. So that's my vision of where maybe things should go. However, these monoclonal antibodies for amyloid aren't without risk. So I've had my patients have, the amyloid also coats and lines the endothelium in our brain, and then they have microhemorrhages, they have cerebral edema. So we do safety checks with MRI. I had a patient have a bleed, a fairly large she was luckily asymptomatic, but she was out of the trial for 4 months until the cerebral edema settled. She and her husband decided to rejoin the trial because it was on the open labeled extension phase. I probably wouldn't have if I were them, so that's the risk. And perhaps people with Down syndrome might have a higher risk of cerebral bleeding and microhemorrhages with these treatments. It's hard to know. How am I doing for time?
Good.
Oh, fantastic. Okay, so there was a small trial, a pilot, 21 people with Down syndrome on simvastatin. I don't know that this is enough for me to put all of my patients with Down syndrome on simvastatin. But with informed consent and weighing risk of benefits, it's probably not harmful. It might be beneficial.
That's a low dose.
Yeah, so, but this was something new that I didn't know because I haven't systematically gone through the literature until you forced me to. I'm glad I did, because this is advancing the treatment. But it needs to have another trial, a randomized control trial with this to really sink it down. But they favored the treatment group for this trial with simvastatin. And the authors said, oh, this is hard to do, but we need to do it again, and nothing's been done. So anybody want to join me? We'll do one from London, a lot of patients.
So I've thought about this many years ago, because I had a patient who's high cholesterol, so you treat, so the family history, you can use the tool to figure it out, but now they have the lipoprotein small a, which is a genetic marker. If it's really high and the person has it, you could justify putting them on it.
Right, you can justify for
treat
that
the-
subgroup that has a high cholesterol.
Yeah.
But if they don't, you don't know enough yet. Technically, like that. Oh, this is another one of my pauses. The horizon. We're gonna march into it. Okay, oh yes, so what are the things that have been shown not to work in people with Down syndrome, as well as vitamin E has not worked in people without Down syndrome developing Alzheimer's disease? So that's a no. The statin use was a risk reduction of 0.47, pretty good for that risk reduction for that one. And then that was another one. The Cochrane, so the simvastatin trials didn't make it into the Cochrane review, but the Cochrane review did, in these studies, what I knew about, and I looked at these that were listed in this Cochrane review, they were the ones I reported on in 2007. And so they, in a systematic way, it favored cholinesterase inhibitor use. Yeah, there we go. Oh, yes, and then within that same Cochrane review, memantine. They sort of, the review is ixnayed memantine, but when I looked at these two trials that use memantine, one, that Haney trial, it was patients over than 40 with and without dementia. Well, if they don't have dementia, how are you gonna expect a change in them? So to me, it's improperly done. Memantine is indicated in a non-Down syndrome population for what we're going to notice is clinical improvement in moderately severe to severe. It's been shown to preserve activities of daily living. It's been shown to reduce BPSD, agitation, and delay it. So you have to know what you're looking for and when to use it. Memantine is not covered by OHIP. It's a self-pay. I'm a little bit uncertain that people who have official disability status, all medications are covered. So I do have a few, no. So then I do this informed consent and say, oh yes, they have my mother created a little foundation for my sister and she has enough money to pay for it. Memantine, even though it's gone generic, is very expensive. For the 10 milligrams once a day, which is usually half the dose for people with normal kidney function, it goes to 20 milligrams a day. It's $80 a month. So it's not trivial. It means, okay, if they have to do a copay for a day program, I tell my patients, please go to the day program. If they have, for my patients without Down syndrome in later stage who have agitation, I find it sometimes miraculous in reducing the agitation they have. But there's been no studies that I see as of any merit in the group of people with Down syndrome with Alzheimer's disease. So I don't believe that. Oh, and then the outcome measure they used, nothing about what matters in life. Function. Who cares what an MMSE score is? Okay, so here's a case. I want you to, I'll read it out loud quickly. So this is that's not really him. That's a Google John. Okay, so John is 48 years old. He's deaf. His first language was ASL, which I'm not fluent in. So I had to have a translator from Community Living London. So he was referred for query cognition. That was the chief complaint. That gives me a lot to go on. So the CLL support worker said, he used to be on time for work. Now he shows up and sometimes he refuses to do the job. He prefers to stay at home. His signing is off topic. Tick, 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 tick. And he's more reliable with his medications. There's an IDL that's going down. Okay, so his past he had hypothyroidism, then he was developing cataracts. So he's essentially legally blind now. Maybe that contributes to his lack of participation in work. He was living independently. This man knew how to take a taxi to get around London. He compensated. He had his address, he'd take out his wallet, he'd show it to the taxi driver. That's where I'm going. Well, he didn't speak, he was mute. But, right, he could do lots of things. He did his own cooking. He could take the bus, he could take taxis. He had a little supervision for his shopping. And his knee was just needing a little bit of help with the self-care when I met him. And then I find my patients usually are insufficient in vitamin B12. I arranged, and I didn't want to start a medication because he was mismanaging the medication. So I had to wait for the community supports to get him to some place or other where they could be supervised, because there's side effects. 15% of people have nausea, vomiting, diarrhea on donepezil, for example. And he got his cataract surgery. That was important. So he moved into a group home. Then I started donepezil. And I saw him like yearly. He was doing great for 4 years. And then he began hoarding. That's another feature that we see in people without Down syndrome often, but I find it a little bit more common. It's sort of an OCD behavior. Mostly it's collecting paper, and they stack the paper and things. Then this was, when I met him, memantine was not on the market yet. And so he just got more and more supports. And then he had did it again. Seizure disorder, and he just declined because Alzheimer's disease, and Dr. Cassie and I were talking earlier, is people don't recognize Alzheimer's disease is a terminal illness. Diabetes is a terminal illness. And you saw from the beginning, people with Down syndrome, they have progeria, they die at a much younger age. So compare his story of care and support from the community to this lady who I just met, well, time flies when you're having fun, a year ago-ish, 15 months ago. And I was just struck because why are they referring her now to me? So she's 54 when I first met her. She came with her sister and a group home worker. And the group home worker, I always ask, how long have you known Jane? 38 years. So more than 10 years ago, she was losing interest and her language changed. And then over 4 years subsequently, she had insidious loss of function. Currently, she was hands-on help for putting on her clothing, for brushing her teeth. She became incontinent of both bowel and bladder and needs hands-on help for that in the past 9 months before I met her. And then because of advanced osteoarthritis, she uses a 2-wheeled walker. So then the functional achievements, she was self-managing bowel and bladder. So she did have the highest level of achievement of continence by age 7. She walked at age 3. She was independent. Maybe her in terms of IQ is the lower end of the range, perhaps, but her environment is the feature that I wanted to compare. She went to CPRI. She didn't learn any literacy at all. Speech and language is always a challenge. Her father died at age 12, and she lived with her mother until 21 with no structure, no group home, nothing. And so when she had CT imaging, which basically moderate severe hippocampal atrophy, and it's too late. She needs a supportive place with good people to care for her. I can really not offer anything to slow the progression, anything. So I just find that incredibly sad. Oh yeah, I thought it was my error in my slides. Did you catch that? Insert picture here. Okay, so to summarize, so the learning goals were list the contributing factors for Alzheimer's disease for people with Down syndrome. So more amyloid, more tau phosphorylation, more oxidative stress. Some have variable education and community supports and variable exercise. So those are some of the highlights. The symptoms associated with the development of Alzheimer's disease, the mild cognitive impairment, MCI of the Alzheimer's type, loss of interest, pragmatic speech changes. Later, it's the memory. Non-pharmacological treatments, healthy diet, supportive environment, interesting things to do. Treat with SSRIs or whatever is going to support the serotonin in their frontal lobes. Pharmacologically, adding in cholinesterase inhibitors have sufficient evidence. Really, the non-pharmacological support is the most important. Oh yes, and aid them in their transitions. Absolutely true. All right, I'm happy. Keep going. I can tell you anecdotes and cases and stories. Oh, wait, more summary. But there's my cat.
Aww.
My cat has Alzheimer's disease. It's on gabapentin because it screams all night long. It has cataracts, which you probably can't see because there's a light here. 17.
Oh, my goodness.
He has kidney failure. His creatinine went from 150 to 270. He has behavior and psychological symptoms of his dementia because he's ripping out his fur.
Oh.
I think I'm getting, this is a transition for me. I have to call the vet and make an appointment for euthanasia. But look at him, he's beautiful.
He's so cute.
Anyway, that's Cat. All right, I digress. But
All
hopefully
right.
it was entertaining.
Thank you very much.
Questions?
Any questions?
Just some comments, an excellent review. Let me introduce this topic. 46 years ago, I attended a hearing for a Down syndrome baby. And the hearing was whether the baby should be allowed to die because of pyloric stenosis. The hearing ruled in favor of yes, the baby should have. And from then on, all over Canada, there's lots of babies being allowed to die, pyloric stenosis. Next step, in the last year or so, I have a good friend, he's a former professor at the university, who has Alzheimer's. And he's very active in the MAID program, medical
I
assistance
know his name.
and dying. And he has an advanced directive
Yes.
there. And he's disappointed, for example, that psychiatric indications are no longer, are postponed. So the big question is, Down syndrome will never be able to give an advanced directive for dying with a view of Alzheimer's. So just a comment in terms of an ethical controversy. I'm not expecting an answer.
No, but there's always outliers in terms of their insight and ability to choose. And I will just stereotype, we can stereotype people with Down syndrome. Oh, they're always happy and friendly. Right? No, they're not. But they would be, to me, they have a tendency to be hopeful. And I'm not sure if before they had dementia, they understand death. I don't think they would choose that as an option, most of them. I don't know. Even the people with advanced dementia, they don't make a predetermined decision.
No, they can't. Dr.
Well, I
Cassidy?
was just gonna I think that the important consideration in that regard as time goes on and more conditions are considered eligible for me is that I would imagine a time where it wouldn't actually be diagnosis specific, but just the capacity to decide, right? And so you wouldn't exclude necessarily anyone with trisomy 21 or any other condition. It would come down to an individual assessment of their capacity.
So, and I have had conversations, yes, in my Catholic hospital, Parkwood. Of course, we're never supposed to bring it up, but when it's brought up, I'm allowed to talk about it. And I've told people, well, so you want to die because you have Alzheimer's. Do you remember the actor Christopher Reeve? I remember reading a Reader's Digest autobiography after he had his accident. He became quadriplegic. He said, before I had my accident, I would have rather been dead than ever live as a quadriplegic. Now that I'm quadriplegic, I have things that I enjoy in my life. I have my family, I have an intellectual life, I want to live. I don't know. So I let them ponder that.
A topic for another day.
Next year's presentation.
So I think there are a small number of people with Down syndrome who don't have trisomy 21, right? You can have a
Yeah, the
translocation.
mosaic, yeah.
Well, not even mosaic, I think they have a Robertsonian translocation between, it's,
My disclosure said I'm not geneticist.
but the information that you presented though, is it only apply to people with Down syndrome due to trisomy 21, do you think, or does it apply to other groups of people with Down syndrome?
They, Alzheimer's disease for other people with Down syndrome?
Yeah, so people, since a small number of people with Down syndrome don't have trisomy 21, does the information about Alzheimer's disease apply to those people as well, since they don't have the full extra chromosome 21?
It's the region of the gene that triplicates amyloid. So there's a case report that I remember reading, I think it was New England Journal of Medicine, of a lady 76 with Down syndrome, and they did medical genetic analysis, and she didn't have the amyloid area triplicated. So that's all I know.
Okay, so depending upon where the
Yeah.
translocation was.
Yeah.
Okay, great, thank you. So just a couple of last things. Just to let everybody know, the presentations will be on our website, which is ddp.uwo.ca. And also, would you please be sure to complete your evaluations?
I will send you a link for an online
And
evaluation.
also, usually there are suggestions for future topics, so if you have some ideas there. And I'd like to just thank Sarah for all her work in organizing.
Sarah, is that a question?
Yes, so this is Dr. Palanasamy from British Columbia, and he has listed a few scales that are free for use for people with ID and screening for dementia. So he says the Dementia Screening Questionnaire for individuals with ID and the NTG-EDSD, and he says they're both free and available online. So the DMR, Dementia and Mental Retardation, he says has also been revised, and now it's called Dementia and Learning Disability.
Oh, that's good.
Did they revise anything else besides the name? Or just-
I'm not sure.
It's a little bit unwieldy to use. I give them a copy of it when they go home, bring it back, and then it will take me 10 minutes to score it. So that's too long of a time for me to score it in front of them.
Can I ask one more question?
Of course.
I feel like I already know the answer to this question, but I'm just curious to know your thoughts. Developmental disability that is not related to Down syndrome. I feel like we still also see, just as these things are common in the population, we see memory concerns arise in this group as well, potentially at an earlier age. I imagine the same principles would apply in the absence of other research that's available in that group. We just treat them all similarly.
Yes. So because with our memory clinic, we have long wait lists in the demographics of the population. So when I first started getting referrals, I had people without Down syndrome, and we said, we're going to become overwhelmed, and this is not our expertise in internal medicine and geriatrics. So we made a decision, because of the Alzheimer's connection, the only people with developmental disabilities to be referred are those with Down syndrome. However, Recently, I've had some people with developmental disability who are over 65. And I treat them the same way. What's your family history? Who has dementia and that? Do you have hypertension? What's your B12 level? All the same. Yeah.
Well, he said it's in color now too. That's the other revision. It's no longer in black and white.
All right, good. Thank you all for coming.